All right. Well, welcome. Hope everybody's doing well. Hope you've been able to familiarize yourself with the syllabus. You did take the syllabus quiz so that as we're doing attendance, I can give you credit. It is imperative that you do that. That is exactly how I'll be gauging your attendance, at least for the first week. So please make sure that you're able to review the syllabus, familiarize yourself with it. You know what's expected of you. There is quite a bit for this class, and that is not just to create busy work. That is to set a foundation that we can build upon in Marriage and Family 2, as well as everything that you're going to do outside of these walls here at this university. And so in that, hopefully you've already done that. You've got your textbooks that you are ready to go as we jump in to chapter 1. And so as we think about marriage and family therapy, there are some there are some complexities. There are some foundational things that we are really going to sit there and dissect. And as we get going, I always like to start off with a question. Now, this question is not a question that you'll find on the quiz for the chapter. It is just something that I think will allow us to just sit for a moment and reflect and assess. Am I called to working with this population? And if not, then there is your answer that maybe individualistic work is a little bit more in your wheelhouse. Either way, perfectly fine. It's all about what God has created for you to do. So why family therapy? Why family therapy? And what I want you to do is I want you to take out a piece of paper and I want you to write that question down. And for the next throughout this semester, every week of the semester, I want you to pull that piece of paper out and I want you to spend just a few seconds, it can be 30 seconds, alone with God and really process that. Why family therapy? I know part of the degree program here at this university is that you get to go through it for credit, for graduating, for sitting for your licensure, those things. But what about you individually? Are you called to group therapy? Are you called not to group therapy, but family therapy, marriage therapy? And when you could go into individual therapy, you could go into group therapy, coaching, consulting. There are so many different venues in this field that you can actually lean into. So what is it about the family that really draws you to this type of work? Now, I've had the opportunity and the pleasure and honor to ask this to hundreds of students over the years. And typically what I find is that the answer to this question always comes back to a relational answer. Someone watched their family struggle and no one helped them as a whole. Someone grew up in a home where no one talked about the real problems and pain. Someone watched a marriage fall apart and wondered if the right help at the right time may have changed something or maybe changed everything. And that pull that they feel, or the pull that you feel towards understanding people inside their relationships rather than in isolation, is not an accident. And that is exactly what this chapter and this entire course is all about. And hopefully by our time together, if I do my job and at least do it well, then we will have defined marriage and family therapy and explain how it differs from individualistic therapy. We'll describe the historical roots of this field. We'll identify the core systemic assumptions that make marriage and family therapy a distinct profession. We'll explain the professional credentialing landscapes, as well as begin to locate yourself in this profession. Really being able to go back to that very question, and is this a population that you feel called to work with? And in that, if you are, fantastic. If you're not, that's perfectly fine. But with that, we need to understand, even if I'm drawn to individualistic work, that individual that I am interacting with, they're coming from a system and they're going to a system. They had a family, and how did that family and or system impacted them to the degree that they are sitting in front of you to that very moment? Or it wouldn't be or, it'd be and they are working, they are a part of a church or whatever it may be. Again, system. And what we want is to let's begin with the most important shift in all family therapy, a shift that everything else is built upon within this course. And really, it helps us to understand how the family model thinking really took place, and really seeing that, is there a problem with individualistic thinking? And so if we say that most of our Western medicine and most of our Western psychology operates on what we call a linear causality, and really that in context is that A causes B. If the patient has a problem, and the problem is inside the patient, then the medical industry needs to diagnose it, treat it, fix it. Clean, simple, linear. Okay, that model works beautifully in a lot of venues. Let's say an individual has strep throat, and the medical industry and the medical field finds the bacteria that is the medical industry, the medical team, gives them antibiotics, which is B. Then the bacteria dissipates. Again, that clean, simple, linear, like I said. With that being said, what happens when a therapist does brilliant individual work with their patient? Really helps them grow, gain insight, grow in awareness, validate, and they experience change. And yet they send them right back into their home, to their family, within their system, and within a couple of months, they're right back as if nothing really had changed. And what we find, those of us in this field seeing that take place, that it has happened constantly within the early days of individualistic psychology. And a group of remarkable, curious people in the 1950s started asking different questions. And the question they asked is what if the problem isn't inside the person? What if the problem is between people? What if the problem is between the people? You see, family therapy replaces linear causality with what we call circular causality. In a circular model, A influences B, which influences C, which circle back and influences A. No singular starting point, no singular cause. There is a pattern, an ongoing, repeating in a relational pattern. So let's talk about this a little bit more concretely. I want to convey this by talking through a case study, if you will. Okay, so we'll call them the family. We'll call them the Martinez family, and you'll see me refer back to the Martinez family throughout this semester. So husband Marco and Evelyn have been married for 14 years. They have 2 kids, Diego, who is aged 11, and Sophia, aged 8. 3 months ago, Marco lost his job, and Elena has picked up extra shifts at work to help with the tension between Marco and her because of all the finances. And during this time, Diego has started having explosive outbursts at school. His teachers says he has an anger problem. The school counselor recommends anger management. So watch what happens when we apply 2 different lenses to Diego's behavior. Okay? Say through a linear lens, Diego has the problem. Diego's anger is inside of Diego. Treat Diego, maybe medicate Diego, send Diego to anger management. Through a systemic circular lens, what is Diego's anger communicating? When the outburst happened, is there a pattern? What is happening between Marco and Elena right before? What does Elena do when Diego explodes? What does Marco do Does their focus on Diego bring them closer together, or does it actually push them further away? And then there's Sophia. What about her? We consider her perfect and quiet, maybe even a little anxious. What role in the system is she playing? You see, a systemic therapist does not need Diego to be broken. In fact, from a systemic view, Diego might just be the most honest person in that family system. He is the one loud enough to say something's wrong. His symptom, there we go, is a signal. And that signal belongs to the system, not to Diego alone. Now, this is the essential insight of family therapy. The symptom, there we go, belongs to the system. And that one shift from what is wrong with this person to what is the system communicating changes everything about how you listen, what to ask, who you invite to the room, and what counts as progress. Now, family therapists have a name for the person in the row of Diego. We call them the identified patient, the IP. And the IP is the family member who has been designated consciously and or maybe even subconsciously as the one who carries the symptom, the one with the problem, the one who gets to go to therapy. The identified patient is not a villain and is not a fabrication. Their pain is real. Just as in this case study, Diego's anger is real. However, the systemic therapist holds a different hypothesis. The hypothesis is if we remove Diego from his family tomorrow, if somehow he was no longer there, would their family be healthier? Or would Sophia start having anxiety attacks? Would Marco and Elena's marriage finally crack open? You see, the symptom has a function and it belongs to the whole system. Now, think about a family you know. Your own, if you're working with clients already, maybe a client, one from a film or a book that you just have just watched or read. Now think about that. Think about that family. Who was the identified patient? And what might they have been carrying for the system? Now that we have the core concept in play, let's understand where it came from, because this way of thinking did not appear out of nowhere. It emerged from a remarkable group of people in the 50s and 60s who were willing to ask entirely new questions. And so in this, I know that you are on a process of your academic career, learning, absorbing, engaging, thinking. Continue to ask questions. Questions are powerful. Just as Jesus himself asked his disciples, so who do people say I am? Didn't ask them a question about what he did. He asked them a question about who he was. And because of that, look at the response that Peter had. If my theology is correct, the first declaration of Jesus as Messiah, and look what Jesus responded to him, all because of the engagement of questions. So I want you throughout the semester to start engaging in questions through the theoretical landscape that we go throughout all the semester. So why did the family therapy model emerge? So to understand that, we need to understand what the mental landscape actually looked like in the 50s. You see, psychoanalysis dominated, individual therapy work dominated. And there was a large unspoken rule in psychoanalytic practice that you could not work with patients and their families at the same time. Think about how that shifted and changed for those of y'all that are already in practice. You're already doing your practicum. What would they believed that actually by working with the same population simultaneously would contaminate the transference. And really from the standpoint, they worked from a model as to keep the family out. However, several researchers and clinicians working independently in different cities were kept running into the same wall. individual treatment, kept producing individual improvement that was evaporated once people went back to their house, when they went back into the same system. And they kept, these clinicians, these researchers kept asking the same question. What is happening in the system that the person is returning to that's creating impact? And the answers came from some unexpected places. You see, Gregory Bateson, not a therapist, he was actually an anthropologist, studying cultures, and communication pattern in the Palo Alto area of California. In the early 1950s, he assembled a research team to study communication in families that had a family member diagnosed with schizophrenia. And what they discovered became the first real foundation of family therapy. You see, his team identified in what they called a double bind, which is a communication pattern where a person receives two contradictory messages simultaneously and cannot win, regardless of how they respond, and they cannot leave the relationship. So the most cited example from their research goes something like this. A mother who visits her son in a psychiatric hospital. When he moves to hug her, her body stiffens. She pulls back, even just so slightly. But then she says to him, "Don't you love me anymore? Do you hear the trap?" If he pulls back and creates distance, he is rejecting her. If he leans in despite her physical withdrawal, he has ignored what her body just communicated and feels like he cannot win and he cannot leave. He is in a double bind. And what made Bateson's work revolutionary was not the observation itself. It was what they were actually observing. And so they were not studying what's wrong inside the patient. They were studying the pattern of communication between the people. And again, if we have a working definition, there it is. That they were studying the pattern of communication between the people. What is it that I'm saying? What is it that I'm doing? What is it that I'm not saying? What is it that I'm not doing? And simultaneously, the other individual as we are conveying. You see, that shift from individual pathology to relational patterns is the intellectual birth of what we call family therapy. And out of his research group came 3 clinicians who began directly applying these systematic ideas to therapy. You have Don Jackson, who is a part of the MRI, the Mental Research Institute in Palo Alto. And he gave us the concept of family homeostasis, the idea that these families organize around maintaining stable, familiar patterns. Even when the pattern is painful, even when it makes members miserable, the system works to preserve it. Because change can be threatening. And because of this, it means that the familiar grounds will always be elevated. And we're going to come back to this verbiage throughout the course of this class, because it will and can explain why people and families and marriages will say they want change and so often resist it when it actually arrives. We have Jay Haley, who was interested in power, he was interested in the power of who has it within the system. Not only that, but who has it, but who doesn't, and how much they have, and the symptoms that often emerge as an attempt by someone without formal power to gain control. And he developed what we call the strategic family therapy. And we're going to look at that later on within the semester as we see his approach, which would be direct, structured, and focused on disrupting the sequences that maintain symptoms. And then Virginia Satir, in many ways the soul of early family therapy and one of the most influential therapists of what we find in our 20th century. You see, Satir was a social worker by training, and she brought something into the therapy room that was not common within the area that she practiced. Warmth, genuine, expansion, unconditional warmth. You see, where Bateson was interested in systems, Haley was interested in power. Satir was interested in people, in their self-worth. And the way we communicate love and pain, and the belief that every person has an innate drive towards growth. You see, her model of the validational process model is what we'll find later on in this, in our course, and we'll dissect it a little bit, is I want you to hold on to her name, because in a field that was dominated by men doing fairly intellectual theoretical work, Satir brought the human being back to the center. And that is powerful. And as we sit across from individuals, we need not to lose the essence of the person. To validate, even when what they're experiencing, we don't want to validate what they're experiencing. We want to validate them in their personhood. And we'll talk a little bit more about that. Murray Bowen. You see, on the other side of the country, in the National Institute of Mental Health in Maryland, a psychiatrist named Murray Bowen was doing something genuinely radical. He was hospitalizing the entire families, not just the patient, so he could study the family system as it actually functioned. Not as family members reported it, as it lived and breathed in real time. You see how radical that was, even in the here and now, much less back then. And what emerged from years of observation was the most comprehensive systemic theory in all family therapy, the Bowen family systems theory. You see, the essential concept is differentiation of self, which means the capacity to retain emotional connected to your family of origin while still being able to think clearly, hold your own values, and act according to your own convictions rather than simply acting to the emotional field around you. Bowen also insisted that you cannot understand a person by looking only at their current family. You need to go back at least multiple generations, what he would consider 3, to their parents, to their grandparents, and to their great-grandparents, because emotional patterns, ways of handling anxiety, those relational dynamics transmit across generations. And we'll spend all of the chapter when we dissect Bowen looking at what this looks like. Because for us to hold on to the idea, we really need to understand a person and understand their multi-generational family. And this is where we get into things like genograms. And there's a couple other individuals that we will talk a little bit more about as well as we continue to dissect family systems. So as we sit there, and what makes marriage and family therapy a profession? So we've talked about the theory, we've talked about the history, we've talked about even some of the early influential individuals that really created the foundation. You see, you're not just entering a theoretical tradition, you're entering a profession. The profession of helping people, helping systems, helping families, helping marriages. And that profession has its own organizational structure. It's not, its own ethical codes, its own credentialing requirements. And understanding this landscape now will help save a lot of confusion down the road. You see, there are 3 things that I want you to be able to distinguish clearly: your professional association, your licensure, and your program's accreditation. You see, these are 3 separate things, and they sometimes can be confused. The American Association of Marriage and Family Therapy the AAMFT is the primary professional organization for marriage and family therapists in the United States. Think of it the way the American Psychological Association is for psychologists, or the American Association of Social Workers is for social workers. The AAMFT advocates for marriage and family professions at state and federal levels. It publishes the Journal for Marriage and Family Therapy, and most importantly for your practice, it publishes and maintains the Code of Ethics the document that governs your professional conduct. And even though I am not a LMFT, I am an LPC, we have a board called BHEC. And in that, we get the opportunity to make sure that we are up to date on the codes of ethics to ensure that we are practicing accordingly. So the AAMFT has several membership categories. As a graduate student, you can join as a student member right now. And you know what? There are some benefits to actually going ahead, even as a student, to being a part of their membership. Student membership gives access to professional resources, networking opportunities, continuing education, and connection to the broader marriage and family therapy community before you even graduate. Now, in that's not because I'm getting any type of plug, but it's for the opportunity of allowing you to get to see the landscape, getting to see behind the curtain before you're able to really take center stage and being part of this. You can be a part of the membership, and that gives you connection. So one clear thing about the AAMFT membership is that it is a professional affiliation. It is voluntary. You can practice as a marriage and family therapist with being a member, and you can actually being one with completely out. So in that, now let's move to the licensure. So the licensure is the legal credential that gives you the right to practice as a marriage and family therapist in your state. In most states, this is the LMFT that I was just talking about, Licensed Marriage and Family Therapist. It is issued by the state licensing board that you live in, not by the AAMFT. And the requirements vary by state. So regardless of what state you live in or you will live in, make sure you understand each state's statutes and you become very familiarized with them. To become an LMFT in the majority of states, you need a couple things. First, to graduate from a graduate degree as a master or doctoral graduate from an accredited university program. Second, a minimum number of supervised clinical hours, typically right around 3,000 total within a specified portion of those being relational or conjoint hours, marriage and or therapy. Third, a passing score on the marriage and family therapy licensing examination, which is administered by the Association of Marriage and Family Therapy Regulation Board, the AMFTRB. I think I got all that right. So I wanted to highlight the conjoint hours requirement because it is unique to marriage and family therapy. Other mental health licensures, the LPC, the LCSW, licensed psychologists, do not specifically require hours doing therapy with couples or families. The LMFT does. You see, that requirement reflects the distinctiveness, competency that defines our field, the ability to work therapeutically with a relational system, not just with an individual. Licensure also matters for something practical. It determines who you can see, what you can bill, and whether insurance companies will reimburse you for your services. You see, without your license, you practice under your supervision. With it, you practice independently. The path from where to here is graduate program, supervised hours, and the exam. Start thinking about it now. The third piece is the COAMFTE accreditation. Okay, so the Commission of Accreditation for Marriage and Family Therapy Education. This is your graduate program. What it is licensing board is to your individual license. This is to your graduate program what your licensing board is to your individual license. It is the external body that reviews and accredits marriage and family training programs, master's and doctoral programs to ensure that they meet the rigorous standards for curriculum supervision, faculty qualifications, and student outcomes. So why does your program's AMFTE accreditation matter to you? Because in many states, graduating from an accredited program streamlines or is required for the licensure process. It is imperative that you know the accreditation. So, the code of ethics. First look. So last major topic for this chapter is, or for our time, is a code of ethics. And if you have not taken ethics yet, perfectly fine. Please do, because it's part of the program. What you'll find is more of an in-depth understanding of what they're asking of you and why, and coming into your own of how do you interpret the code of ethics so that you can sleep well, look at yourself in the mirror, and make sure that you are not doing anything that is considered unethical or a breach of ethics that can get you and or uncover your client in the process. So the AMFT code of ethics typically covers what we consider 6 major areas: responsibility to clients, confidentiality, professional competency and integrity, responsibility to students and supervisees, responsibility to the profession, and responsibility to society. And we'll go through these a little bit more in detail, but I wanted to flag something right now that is specific to our work as family therapists, something that individual therapists rarely have to navigate in quite the same way. When you are in individual therapy, your ethical obligations typically flow primarily toward one person, your client. Yes, there are exceptions, mandatory reporting, duty to warn, but your primary loyalty is clear. Now imagine you're working with a couple. Both partners are your clients, and in the session, you learn from the husband, and in the individual phone call, and in the session, you learn from the husband in an individual phone call that he has been having an affair for 3 years and has no intention of telling his wife. Do you owe your loyalty to? Who do you owe it to? What are your ethical obligations to the wife, to the husband, to the relationship, and which is also, in some sense, your client? There is no easy answer to that question. But the code that the AMFT provides a framework, but it does not provide a script. And this is really the ethical practice of family therapy, because we have multiple clients in the room simultaneously. We encounter competitive loyalties, competing interests, and competing needs, and we must navigate them both with ethical clarity and clinical skill. For now, I simply want you to hold the question. As we look through this week and throughout this course, notice how the systemic frame doesn't just change what you do clinically. It can change, and majority of the time it does, your ethical framework and landscape. Informed consent, confidentiality, the definition of who your client is, all of these will get more complicated when the client is a system. That complexity is not a problem to be solved. It is terrain of your work, and learning to navigate it thoroughly and thoughtfully is part of what it means to be a family therapist. How you doing? We've gone through a lot. I think give me just a little bit more time and I'll land this plane. Your professional identity. Who you are determines a lot about what you do when you're sitting in that chair. And your professional identity, who are you in Christ, and who are you as that individual sitting in that chair across from the family, from the marriage, from whomever that may be. So much about what we do runs underneath from who we are. You see, you're not just learning a set of theories, even though you are becoming a kind of clinician. And that kind of clinician as a family therapist is very specific. It is someone who has deliberately chosen to work with systems rather than individuals, who understands that the problem is never simply inside one person. You are someone who can hold multiple people's reality simultaneously in a single room or on a single screen, who believes, and this is perhaps the most radical thing about family therapy, that the relationship can change. And when relationships change, people can thus change. You see, that belief is not naive. That is not wishful thinking. It is supported by decades of research, which will continue to expand between this and Marriage and Family 2. But it's also a stance, a way of orienting yourself towards families that refuse to reduce themselves to the worst moments or their most entrenched patterns. You were drawn to this field for a reason. Some of those reasons you already know. Some of them you will discover as you sit with families who are struggling, as you feel the pull of their pain, and as you learn through supervision, through experience, and through your own personal work, how to stay present with it all without losing yourself. Let me leave you with this. Family therapy is not individual therapy with more people in the room. Some people believe that that's what it is. It is a fundamental different way of understanding human problems, grounded in circular causality, relational patterns, and the view that that the symptom belongs to the system. Second, the identified patient, the person labeled as the problem, is rarely the sole source of the problem. The symptom is the signal of the system. A systemic therapist asks, what is this family trying to say through the symptom? The emerging 50s and 60s and all the individuals and how they contributed to what it is that we're studying in the here and now. The three distinct pillars that we need to understand as we move forward, become licensed. And the ethics in family therapy is more complex than what we could say about the individual therapy, because you have multiple clients simultaneously. Confidentiality, loyalty, and informed consent all carry additional layers when the client is a system. So, something to kind of help us get started. This isn't for a grade, this is for you. I want you to describe a time when a problem in your life or a family you observed was influenced by relational or contextual factors. Using at least two concepts from the opening chapter of our text, whether circular causality, identified patient, systemic thinking, or family homeostasis. I want you to explain how that systemic perspective would understand the situation differently than from individual approach. What does that reframe reveal that was previously visible? And by doing these assignments, even though they're not graded, what they give you is an opportunity of homework. And I give my clients homework all the time. Why? Because it has the opportunity to expedite the process. And so in this, if you choose to do so, which again, I'm asking you to, is for your benefit, is looking at the difference. So as you make a further determination of, am I going to work with individuals or am I going to work with this population?